can continue low flow oxygenation as less than 5 liters per minute during the apnea period for these patients. Now, when we say the other resources, as I mentioned, the trolley inside the theater and outside should have all these equipments which are very essential for airway management. So once it fails, the second step would be the insertion of our supraglottic airway devices. Now, when you have a transition between the two, at times the patient may be desaturating. You can use bag and mask ventilation. But remember, it should be done at low flows. There should be a good seal and a gentle mask ventilation so that the dispersion or the leak around is much less. So this is what we are targeting at start with for unanticipated difficult airway, but ensure that the second step is ready, and which would be a supraglottic airway device for oxygenation. It has to be a second generation devices because the leak, the seal is much better. So use a second generation device for this. Give not more than 2 attempts, but if you think between attempts patient desaturates, you can go with gentle mask ventilation as I mentioned earlier, and you can use different type of second generation SAD or a different size depending upon the first failure or success rate. And sure, in COVID-19, what we are wanting is a good anesthesia and good neuromuscular blockade, because if the patient cough and bucks during this procedure, the chances of aerosolations are much higher. It has to be ensured at the first step that the optimal neuromuscular blocking agent has been given. If not, you can repeat it here again and ensure that the optimal neuromuscular blockade has been achieved in these patients. Now, once you have done it, if you are successful, you can continue, depend upon the patient profile and the surgery that you are doing it. You think supraglottic airway devices have some possibility of increased aerosolization, especially when they are not having an optimal fit. But if you think the surgery is urgent and it needs to be done, if you're safer, you are using some type of containment devices, you can go ahead and do it. Tracheostomy or tracheal intubation through SAD are not preferred because with opening of these, the chances of dispersion of the aerosols are much higher. So that needs to be taken care of. Now herein, if the SAD fails, you are not able to maintain oxygenation, then you have to come through the next step. And this again becomes more difficult. And the next step will be the rescue phase ventilation. Now, we are not attempting any different type of interventions here right now because the chances, each chances will have increased aerosolization, and that will increase contamination to the healthcare worker. So herein you can use face mask ventilation, but as I mentioned earlier, whenever you attempt face mask ventilation in any of the cases, whether anticipated versus unanticipated, ensure that the grip is good. Use two-hand techniques. Your assistant can provide a mask ventilation, and the flow of oxygen should not be much higher. And as mentioned earlier, we will be expecting that you are using HME filter, HMEF for these attachments so that the aerosolization or dispersion does not happen. Now, in case if you succeed, you can awaken up the patient, and then you can plan subsequently further on for depending upon the urgency of the surgery. But in case if patient cannot be awakened up or the patient has failure, is not able to maintain oxygenation, in that case you have a complete ventilation failure. Now here comes a situation, it's a dicey situation. The literature is not very robust whether the tracheostomy or the surgical access is free of aerosolization. But having said that, the option, because patient is not able to ventilate, we have to go for emergency cricothyrotomy. We have ensured a good amount of optimal neuromuscular blocking agent so that when we are giving an incision or putting up a tube, the chances of coughing and bucking are less. And we can continue nasal oxygenation here. Whenever the nasal oxygenation is being offered and you are not attempting, you can keep a mask, or at times in the beginning, you can have a surgical triple layer mask over them so that the aerosolization is much reduced in these patients. The usual technique for surgical access would be using a scalpel bougie tube technique, and that is a faster procedure, and you can use a smaller size 6.5 tube for ventilating, for putting up the airway into this, inflate the cuff and then try ventilating them. Now, whatever we said, for even for unanticipated difficult airway, be cautious about the post-procedure plan also, because this patient was not simple. They have some difficulties. The chances of use of multiple equipments would be collected here. The first step we said in the airway management, minimal equipment inside the operation theater. But once you are into the category of unanticipated, you will be getting the airway card and the equipments will be much more with you. So ensure that all those equipments are properly disposed because they are source of infection. They have been inserted into the oral cavity, into the nasal cavity, and the chances of aerosolization could be there from these equipments. So ensure that they are properly disposed of. Obviously, you have called for help. So these patients, these healthcare workers, while managing these patients, they should be properly doffed off and they can leave up when the airway is managed so that everybody remains safe and the minimum persons of people are there inside the operating room. So having said that, for any airway management and when you struck up with an unanticipated difficult airway, always try to look for the safety of the patient as well as the healthcare members. It is very, very important because we don't want to lose ourselves and the healthcare workers during airway management. The techniques that we're using, we are not giving you an armamentarium of multiple techniques. It has to be very crystal clear, plan A, plan B, plan C, and there should not be a confusion and with good communication between the healthcare members. Whatever the technique you choose, it should be under your expertise, and that's why we suggest that whenever you plan something, even like for example, say use of the containment boxes, it will be good if you can do some practice or some rehearsal or a drill before you start doing these procedures on a mannequin using all those equipment. So it will be very safe and you will be able to do it timely without rush or delay. That will provide not only safety to the patient, but also safety to the healthcare worker. So to summarize, airway remains an aerosol and it becomes a more of a risk when we have multiple attempts and that is there in an unanticipated difficult airway. So always be prepared. Prepare the patient, prepare the team, have plans and alternate plans so that the airway success happens. And the last statement that is, I think is very, very important in this COVID. We have been talking of the airway management workshops, hands-on practices. Though we have some of us may be so-called experts, but now since we are using new equipment and new strategies, we need to practice and learn these new skills in a new environment again to make us more confident in managing these patients more successfully. Thank you so much.
And would you use suxamethonium in an unanticipated,
Yes.
or rather where the airway is not anticipated to be difficult? I think that was the corollary question. Your views on that? Rakesh, would you be having a different opinion or the same thing as whatever
opinion? Just I think there is no controversy with regards to the use of any of these drugs, scoline versus rocuronium. The basic crux is an optimal neuromuscular blocking agent. This is one, and there should be a rapid acting. That's it. I think that's the basic thing. So if somebody does not have a contraindication to use of succinylcholine, please go ahead and do it. We do not have a very robust evidence as of now, but these are based on presumption of the beneficial effect of these drugs.
I think agreed, Rakesh.
No,
I think Dr. Amit, I think you have got your answer to your answer that even in the OR, what you don't want is bag mask ventilation. So use an agent you are comfortable with, which will give you the earliest conditions to intubate the trachea, and provided the patient conditions are nothing, which will prevent you from the using suxamethonium. So you won't be using suxamethonium if the serum potassium is 6.5 or something like that. Otherwise, I think the go-to relaxant would be suxamethonium in the opinion of all the experts that we have today. I think we'll go to the next question. Krishna, you can take the next question.
Yeah. How about using the LMA in the difficult intubation situation? Shall we use the relaxant or not? Rakesh.
Yes, Rakesh.
I think
difficult intubation.
Yeah,
if you are using the element, do you need to use the relaxant or not, or what is the choice of relaxant?
So when we talk of the COVID-19 patient, the basic principles are use an agent which provides you complete relaxation. So that's why we are talking of optimal neuromuscular blocking agents for all of the drugs. We are not talking of spontaneous ventilation and securing the airway with regards to the management of airway. This is first principle. Second is the gazette. When we say gazette, use a gazette where is no risk of the release of expiratory air while ventilation. So we are not putting up the supraglottic airway device as the first modality of airway management in COVID-19. But yes, If you are failing in the first management with a definitive airway of using a cuffed endotracheal tube, if we are failing it, we can use as a rescue measure, and preferably we are not going with a classic LMA or something like this. It has to be a second generation which provides a better seal, and obviously the chances of dispersion would be there, but second generation would have lesser chances, and then they can take a decision whether to go ahead with the surgery. Having said that, when we use these equipments, I think we have discussed during the webinar, we have to take precautions of the aerosols which are being generated from the airway, that they are not going into the environment of operation theater. So we can use certain containment device, whatever they are comfortable with, so that even if there is some generation of aerosol, they are not going to the healthcare worker, and the chances of contamination will be much higher.